Hello, welcome everyone. Thanks for joining our talk. My name is Isaac Palka. I'm here with my colleague Tim Laurent, and we're both engineers at Invitae. It's a public company primarily known for genetic testing. We focus on a product called the Digital Platform, which we'll get into today. Basic problem we're trying to solve, next slide, is the challenges of utilizing your medical data. So if you think about it, your medical data is scattered throughout the healthcare system. Some of it's digital, much of it is not. So the problems with digitizing it and getting it to a usable state is A, the data is highly unstructured, inconsistent. Anybody who's tried to get their medical data knows that there's no real standard for it. It's pretty large volume per patient. So especially if somebody is sick, has a disease, patient can have hundreds or sometimes even thousands of pieces of paper representing their whole medical history. And then even something basic, just like getting it online, you have problems often with the quality of the scans. It could be poor contrast, the orientation or rotation of the screen, of the page, the layout, etc. And finally, there's also a lot of unuseful information in all these documents. So if you want to get something, a key piece of data, such as your medication or which genetic mutation you might have, it can be like finding a needle in a haystack. Our goal is to make healthcare data structured and queryable for the advancement of healthcare. And to be a little more specific, next slide, please. We're here to serve the patient on one side, and first and foremost, make it easy for the patient to manage their data, search it, share it. So rather than lug around 1,000 pieces of paper and bring it to the next doctor and have them try to figure out what's going on, make it all digital, searchable, etc. And then if you blow this up on a macro scale, you do this for millions of patients and you have their data structured. This enables real-world data, which is a big improvement and the newest trend above clinical trials, which expedites things like research and drug discovery. If you think about a more specific example, you want to develop a precision medication, you need a very narrow cohort. You need very granular data on what's happening with that patient every day, every week. And that's ultimately the problem that we're working on solving. So brief agenda for today. I'll introduce FHIR, which is the healthcare standard of choice today, which is the end result of our entire pipeline. Then I'll hand it over to Tim to go back from the beginning and talk about how Invitae's ML platform gets us there from the raw PDFs, specifically how we process the visually rich documents and then extract the key data and convert them into FHIR-objects or FHIR resources. And feel free to ask questions in the chat as we go along, and we'll wrap it up at the end. Cool. So let's introduce FHIR, pronounced F-I-R-E, but it's really spelled F-H-I-R, as you can see. Next slide. In short, it's a healthcare protocol, a standard that was invented in 2014 over HL7 version 3, which failed to get adoption for a number of reasons. So some of the benefits of FHIR include, A, you have the concept of a resource. This is basically a data model or an entity, and they've developed over 100 different resources to describe any kind of concept you'd want to describe in the medical space. And I'll show you some examples. It is REST API friendly. It's not required. You could use things like GraphQL if you want and others, but it makes things really easy when you're talking about importing or exporting data. It supports your most common formats, such as JSON and XML. They have a lot of helpers, I call them, like these useful concepts like codable concept, structure, definition. And I'll show these by example in a few slides, but it makes them really easy to work with this protocol. And lastly, I think you'd be hard pressed to find a concept that doesn't already exist in FHIR, but if you do find something that doesn't exist, it's pretty easy to extend it, and they give you the guidelines to do so. So this is a very partial list of some FHIR resources. You see here you have things that are related to actual healthcare, like allergy, condition, procedure, medication. Then you have things that are more organizational or administrative, such as the concept of a patient, a practitioner, organization. And there are many, many others which you can easily find on the internet. But the idea is these describe anything that you'd need medically. Next slide. This is an example of one resource. So you see here, a resource is really just a set of attributes. So the condition resource, for example, has fields such as category, severity, encounter. Most of these refer to a codable concept, which basically means it refers to some kind of standard code like SNOMED or ICD. And you have things that are also date ranges, numbers, etc. So it's pretty intuitive and readable and easy to use. By comparison, this is how it looked in HL7 v3. So it's no surprise that this failed to get adoption. If you do find this intuitive, then God bless, but most of us don't find it so. So ultimately, the problem we're trying to solve is start from the left side, this PDF, and you see here, there is an onset date of this epilepsy condition. There's a mention of a genetic mutation, STXBP1. We're taking this unstructured data and structuring it into the corresponding fields in the FHIR resource. And on the left, this is just a snippet of our application. And it shows you we're using something within FHIR called a structured definition, which is basically our subset of the FHIR resource and our interpretation of which field is required, what are the allowed values for a given field, etc. And when you start creating multiple FHIR resources, you have what is called a resource bundle, which is just a set of resources and the relationships between each other. And this is the key. This tells you the picture of what's happening with the patient at a given point in time. If you hit next one more time, you'll see every resource is really just a set of attributes. So it's kind of like doing data modeling. Your patient has their name, gender, birth date. The patient has a condition, which has a category, a severity. The condition was noted during an observation. And the condition is even linked to a provenance, which is just evidence, which comes from a document reference, which is the PDF. So the idea is, you can blow this up even much further, but this tells you actually what is going on with the patient. Next. So I showed you basically what's the end output of our entire product. Now I'll hand it over to Tim, who will start from the beginning and show you how we arrive there step by step.
Hi, my name is Tim. I'm a engineer at Invitae working on our information extraction processes. I'll talk to you today about how we use Invitae's machine learning platform to achieve our goals of serializing health data from unstructured medical records. So Invitae's machine learning platform consists of labeling components, training and model selection, model serving, and ontology linking components. Here's a bird's eye view of the entire system, and we'll go into each of these areas more specifically in the next slides. Our data labeling platform, we use Hardex's Label Studio, which is an open source machine learning labeling solution. It consists of a number of task widgets that can be composed into custom labeling workflows. We've had a great collaboration with them, and we've even been able to take custom labeling interfaces that we've developed in-house where we can label the OCR bounding boxes on a PDF directly into the tool. So it's been a really collaborative relationship with them. We use Label Studio for NER labeling, relation labeling, document task labeling, optical mark recognition labeling, and even ontology linking through their free text feature. Hopefully, the API can support our very large list of ontology entries soon. So our labeling workflow, when we want to rev new labels, consists of first labeling a small data set, so maybe 50 or 100 PDF pages. Then we fine-tune a pre-trained model on this data and use that model to label a larger data set, maybe 500 to 5,000 examples. Then we have our labelers correct the model's predictions. We review the corrections And then finally, we split those data into train, test, and validation splits based upon the patient. It's important that we do split it on the patient so that we don't have any data leakage between our training and test splits. And then we log these data as weights and biases artifacts, so we have a static data set so we can reuse and compare in our modeling exercises. For training, we rely on weights and biases sweeps, which is weights and biases hyperparameter tuning product. We have a training CLI where we can provide a weights and biases sweep configuration YAML. There's an example here on the page. This tells us how to run the model, what hyperparameters to use, and for example, learning rate or batch size. We also specify which Docker image to run, and then also a compute budget, the number of pods to run, and the number of runs per pod, and then what type of hardware we want to run this on. After submitting that, the number of pods that we specified will be deployed into our Kubernetes clusters using Kubeflow pipelines, and then they'll poll the weights and biases server for hyperparameters to use in training experiments, and stream the metrics and any evaluation results back to weights and biases where they can be compared. You can see this parallel coordinates chart where we have one such experiment. You can see all of the hyperparameters that we used and then the ultimate evaluation metrics. But we also log more rich examples such as logging predictions and our ground truth examples so that we can look at it. We can do error analysis between how the model's performing, or even detect areas where we have labels that are improperly specified. We also do other per the use case. We also do other visualizations like precision recall curves, ROC curves, and then after we've done this, we can select the best model to promote to our to the weights and biases model registry. And that brings us to our model serving. So now that we've selected the model we want to use, we can do serving through our API gateway. All of our inference comes through the API gateway that we've written in Fast API, and this handles things like authentication and authorization, and then proxies requests to our inference services. Our inference services are built on Kserve, which is a cloud-native function as a service for serving machine learning models. We can deploy an inference service using a single Kubernetes manifest. This enables request-based auto-scaling and enables us to control container concurrency, which helps to avoid OOM errors when we're serving these models at scale. We also get a request queue, which ensures first in, first out priority of handling model requests. All of these things we don't get out of the box with any Python web server. Then our inference services pull the models from the weights and biases model repository and serve them in this platform. And we've written our inference services using Fast API, Selden's ML server, and hopefully we'll be deploying some models on Triton model server soon. This brings us to the last component of our ML platform, and this is our linking service. So the foundation of our linking service is our ontology database, which holds 1.3 million distinct concepts from the Unified Medical Language System, or UMLS. It's a subset of the UMLS that we care about, and you can see the constituent ontologies that we have in the number of elements here. The key to being able to search these is to have an index that we can use to take candidate concepts and link them to the ontology service. So for every concept in our ontology, we embed it in two different ways. One is a structural character-based TF-IDF embedding, and then the other is a semantic contextual embedding. For that, we're using a sentence transformer with SAP-BERT, which is a BERT that's pre-trained with a contrastive strategy to ensure that every concept is separated properly from other concepts, and they all cluster together. When we have discovered concepts from our extraction pipelines, we embed those in the same way and then use those as queries to our retrieval indexes. And we use those to gather our ontology link candidates. So for processing visually rich documents, we rely on the layout-LM models that were developed at Microsoft. These are multimodal models that combine both the words bounding boxes or layout, and the image. And they have innovative self-supervised training paradigms that align the words with the image to provide a really good representation of a document. Right. We use layout-LM as the backbone for our NER, for our NER tasks, for table comprehension, optical mark recognition, question and answering tasks, and for relation extraction. So now let's talk about how we use this platform to make candidate FHIR resources. How do we go from these unstructured documents on the left to these structured resources on the right? Let's talk about the overall machine learning aided FHIR annotation process. So, the first parts are OCR. We get the OCR from the documents, and then we classify the documents using a multi-label classification model. We extract and classify dates, and then for every class of documents, we send those to specialized extraction services for extracting a specific type of FHIR resource. We have some for conditions and diagnoses resource, genetic biomarker resource, test results service, and medication service. And then for each patient, we need to rank those resources, those candidate resources, to be shown into the UX. The medical document annotator then uses those candidate resources in their annotation processes, adds missing data, and corrects any errors. And then we use the feedback to train better models and to tune our ranking algorithm. So the scope of our modeling, I think it's important to talk about. It's intractable to model all of FHIR. As Isaac mentioned, there's over 100 resources, and we need to focus on what's most important for us and for our annotators. So the three primary resources that we've been focusing on are condition, and these capture things like primary diagnoses, for example, Alzheimer's disease, or other comorbidities like hypertension. Observation, and this we use for capturing diagnostic test results and any symptoms that might be associated with a condition. And then medication statements, which is important to establish a history of medication for the patients. So the information extraction modeling steps that we must generally take are named entity extraction, asking what is this object, relationship linking for grouping the associated entities that we've identified. For example, a problem has a body location and age of onset, or date of onset, or age of onset, and the severity. And then assertion typing. This asks, is this about the patient? Is it negated? Is it a speculative comment? Or is it about some other person mentioned in the narrative? This is a crucial step because there are many, many concepts that we can identify in somebody's medical records. And we want to make sure that the annotators are getting information that's actionable and usable in creating the longitudinal history for the patient. So otherwise, the machine learning is unhelpful. And then finally, we do the ontology linking. And that's asking, what's the most specific code of this concept in our knowledge base ontology? So now let's talk a little bit about the design of our candidate FHIR-object extraction services. So these use a feature store pattern rather than adding pre-computed intermediate data from prior steps. So this decouples the task from the implementation. So this allows us to have flexible modeling approaches, where here in this example, we have two different ways to extract this data extract the genetic biomarker data from a PDF. One of them uses the NER relation extraction, ontology linking, and assertion classification pipeline, as we described before. But the one on the right uses an end-to-end information extraction using a generative model. For example, we could use a new model like Donut or generative IE for pulling out, both the NER relations and the ontology links all in one step, followed by assertion classification. Having this contract that we're operating on the page ID instead of previous data or intermediate data allows us to switch out these implementations without affecting the overall workflow. And then finally, we return the candidate FHIR-objects. These may be missing fields. We might not have everything there. We might have incorrect dates, or perhaps there are genetic transcript identifiers that appear in the appendix of a genetic report. These might be wrong, but we rely on our data annotators to fix these issues. So now let's look at some specific examples of how we are using our machine learning pipelines to pull this data out and create these FHIR resources. For table comprehension, these are very high value for us because they are used for communicating diagnostic test results and medications the patient might be taking. And every row of these tables corresponds to a FHIR observations in most cases. And they're usually about the patient, so the assertion typing isn't as important. So for this example, we want to go from the unstructured document on the left to a structured form of test value unit on the right, seen in this example. So we first use a LALM v2 NER example that encodes test value in unit. And then we transform these predictions into a visual representation and use computer vision object detection to extract grouped rows. And then we link to the LOINC codes for the specific tests that they represent. Invitae also has a number of optical, we also use it for optical mark recognition. So Invitae uses a lot of hierarchical forms with nested radio buttons, printed and handwritten values like is shown here on the page. For this extraction, we use LALM v2 to detect all of the values, both printed and handwritten in the form, and then a computer vision approach to extract the radio buttons. So this is a two-phase process currently where we first use OpenCV to extract candidate radio buttons, and then we classify them using a fine-tuned ResNet into checked, not checked, or not a checkbox for other artifacts that aren't checkboxes. And then we use a heuristic to link the checked radio buttons to the values that they represent. And then we link those to an ontology. So here you can see that breast cancer is checked. It's also a triple negative breast cancer, HER2, ER2, HER2, and PR negative. The age of diagnosis is 51, and this is a bilateral breast cancer. So you can see that we are able to link this to the specific code of a triple negative breast cancer in SNOMED, give it a body site of both breasts, and an age of onset of 52 years. And then finally, we have an example where we extract this information from a genetic report. This uses textual-based NER, a QA-based relation extraction model to link up the different utterances with each other, and then we link to terminologies using specialized services. For example, pulling out HGVS segments like the amino acid change or the gene change, and then we add that to a FHIR resource. So to summarize, we believe that FHIR is the key to transforming this unstructured medical documents into structured data for downstream clinical applications for both the patient and for any entity that might be trying to help the patient for new drug discovery, for new therapeutics. Invitae's machine learning platform supports diverse approaches for doing this information extraction of unstructured data from visually rich documents, and we spend a lot of time on thinking about how we can best extract this information. We take these imperfect candidate FHIR resources that are very close to what we need ultimately to annotate, and that helps to streamline the manual medical record annotation process. And then we use the feedback from those annotators to improve the extraction models and the ranking algorithm. All right. So I'd like to briefly acknowledge the people's work that went into this. They're all listed here, and with that, we can pause for questions.